In the United States, thousands of people are locked away in psychiatric wards against their will every year, often for reasons that have very little to do with genuine mental health problems. In this video, I'm going to sit down with Rob, who's extensively investigated how and why involuntary psychiatric commitment laws are manipulated to expose the uncomfortable truths hiding behind these closed doors. Rob, so good to have you on the show today. We're going to be talking about involuntary commitments, which was the topic of your recent book. What was the name of the book, Rob?
Your Consent is Not Required: The Rise in Psychiatric Detentions, Forced Treatment, and Abusive Guardianships. Yeah. And so I have a sort of an anonymized cameo there because I was interviewed by Rob way back in the day before I guess I was working independently and I didn't want my name coming out. And so I kind of have a connection to this book, and I've been wanting to have Rob on for a long time to talk about how out of control involuntary commitment is in the US. So Rob, thanks for coming on and talking about your book with us. Yeah, thanks for having me. And it's great. And thank you, for your contributions to the book and the conversations we had at the time. And it's nice to see that you're feeling more comfortable and able to kind of come out and be public about your views on all of these issues and topics.
Isn't it crazy? I mean, it's almost as if we live in a totalitarian society where I thought I was going to get hauled off for having the wrong ideas about psychiatric care. And gosh, sometimes it feels like that. But I always think it's funny that I was like, oh, I want to be anonymous. I want to be anonymous. What if other people see this? But it's real. It's a real pressure out there for people.
Oh yeah, absolutely. I mean, and I know sources that I've had, people that work within the system in different capacities have gotten real blowback from speaking out in different ways, whether it was with me or just in some other context in their lives where they spoke out. The people do get in trouble for it. They do lose opportunities in the workplace. So that's real. And in fact, that might be one of the biggest problems. We don't know how extensive that really is out there, where people are thinking critically within the system and feeling not able to speak up. There might be an incredible, movement of people out there that we haven't tapped into yet who are working within the system. I don't know if you have any sense of that from your time. Sense of what? Sorry? Just how many people are truly thinking critically who work within the involuntary commitment system in some way, shape, or form, whether they be social workers or psychiatrists, but how many people there are actually kind of going, I'm not comfortable with really this whole system, although I play this role in it.
Well, the thing is, I think it touches everyone. I feel like the involuntary commitment system bleeds into this overall dissatisfaction that professionals have within mental health. And I see it in the comments to my YouTube videos. I see it on Reddit all the time. I see it on Instagram. People are just saying, I'm so disenchanted with mental health because, one, they're disenchanted about the medications, the lack of efficacy, the withdrawal problems, how the drugs harm people. But two, that they work in a system which deep down inside they know doesn't really help that many people. There's huge amount, when it does help, that's great, but there's huge amounts of collateral damage. A lot of people know that they use involuntary commitment, not because it really helps people, but because it's just easy on them and it's easy on the system, and they can just kind of shuttle someone from one setting to another without maybe having to get that involved in the case. And so I think in the broader context of the just general dissatisfaction with how poor the quality is in mental health, I think involuntary commitment is playing a role there.
Mm-hmm. Yeah. I remember in our discussions, you talked about the frustration you experienced sometimes feeling like, there was only so much you could do in the psychiatric ward to help a person. And you could readily see what this person really needs is maybe help getting housing, better housing, some kind of supports in their daily life in some way. And we've seen studies of that too. And I think that's one of the most interesting things that's under discussed, even though involuntary commitment is in the news all the time, particularly targeting, very aggressively now people who are unhoused. At the same time, we have quite broad investigations in some places where they found that mental health professionals were not keen on working with some of the people who are most struggling, because they could feel that, I think. Like, they didn't really know. These investigations didn't reveal what the reason was, but what they could see is that both police and psychiatric hospitals and general hospitals didn't really want and would often turn away some of the most severely troubled people that were being brought to them repeatedly over and over, because they just were seemingly just becoming cynical about it.
Mm-hmm. Yep. Yeah, that's certainly true. I mean, I remember when I was in the emergency room, I mean, some places they just give up on patients, and sometimes I don't even blame them, because I remember most hospitals have seen a patient like this. It's called like the swallower. Like, it's the person that constantly comes in with swallowing sharp objects and things like that. It's like a compulsion. It's also kind of like very like sort of like a manipulative thing that can happen. And I just remember there was this one patient, she kept on doing it, and it was like on the do not admit list there. It was just like, whatever happens with this patient, we don't want to be involved.
Wow.
And so, yeah, they do, because it ends up being a dispo issue as well. Like, can you imagine placing, hey, we have this autistic patient here who's been in the hospital like 7 times this year for swallowing, thumbtacks, and families given up on them. The care homes have given up on them. And so they just end up sitting like rocks on the inpatient units, and then the medical directors and the person who holds the purse, because they pay for it, they're just like, every time this person comes in here, it's, $50,000, and they're just like, we're just not doing this anymore. Like,
right. Now, that is so interesting, right? Like, I think that, I mean, it's a terrible story, obviously, but also at this other level, I'm thinking of how important and interesting it is to hear that, because this is the kind of thing that needs to be spoken more publicly, I think, so that, in a sense, that legislators and the general public doesn't get the impression that, someone like that, the answer is involuntary commitment, and that will solve the problem. Because it's often sort of these extreme cases that someone will cite and as a justification. But what we're hearing here is no, that doesn't really necessarily solve the problem either. And so we as a society should be revisiting those kinds of extreme cases and really saying, well, what does it need? Maybe psychiatry has a role there in some of these cases, but probably not the only role. And what other kinds of skills and abilities and approaches can we bring to bear in these kinds of situations? And I think that would be a much healthier public discussion to be having. And I wish more psychiatrists would speak out about those kind of cases in that way, to highlight, just, whatever it might be, restraining or tranquilizing this person for a while is not really a viable solution. So we need to talk more robustly about what's really going on.
Well, Rob, let's shift gears for a moment, because I want to set the tone for our discussion today. Maybe you could just start by telling us what involuntary commitment is, and we can kind of explore this topic that may not be familiar to some of the listeners.
So, every state in the United States is state law rather than federal law, and in Canada and basically everywhere in the world has these kinds of laws, but both in Canada and the United States, it operates at the provincial, the state level, where there is something that's usually called something like a mental health act. And in that, the prime reason for the existence of that act is usually to create some sort of framework for treating people against their will, for detaining people for a certain period of time in a psychiatric hospital or psychiatric ward in a general hospital, and examining them, making some determinations, potentially giving them psychiatric medications against their will, potentially electroconvulsive shock therapy against their will, or any other treatments that might be available. And so this framework is surprisingly broad and powerful when people really look at it. There's a sort of narrative out there that, oh, we hardly do this at all anymore. And, sure, back in the 1950s, there were these big state asylums. We locked people up in. Well, we shut those. And so it hardly anyone has this happen to them. And what I found in my research is that it's really the exact opposite. We don't have great data to compare the 50s to today, but certainly since the 80s and 90s, we can start to track wherever we have decent data that the rates of especially short-term involuntary holds, they're often called, a sort of period of time that can vary from about a day to a few days to even up to several weeks and past a month in certain states, where a person is held for a period of time in a psychiatric hospital against their will, basically incarcerated. They're imprisoned in this environment. And in a lot of these kinds of places, there may even be bars on the windows, locked doors, restraints are used, there's security guards there. And so it can be quite an intimidating and threatening environment. And so those numbers are going up and up and up over the last decades. And really at astounding rates that we can, delve into more if you're interested. But alongside that, then also there's an expansion of forced treatment. So there's that detention component. And then I like to separately talk about that impetus, that part of the law that allows people to be actually treated against their will with different types of psychiatric medications, most commonly and sometimes electroconvulsive shock therapy. So that's basically what involuntary commitment is. And my book is an exploration of that, how it's being implemented primarily in the contemporary context. There's a lot of great books out there that look at this in a historical over hundreds of years. And I mention a little bit of that, but mainly my book is focused on what's going on today. What is the contemporary face of involuntary commitment?
Yeah. And Rob, is there a story as to why this jumped out at you as a topic you wanted to write about? A personal story, or is it, a fact that you found and you just had to keep on digging? How did this make such an impact on you as to write a book?
Yeah, there were a number of touchstones in my life where I would notice little hints about people being locked up in psychiatric hospitals. I'd read about it as a child as stuff, and it never seemed like a very nice thing to have happen to you. And then it actually happened to my father. He was going through a difficult period. I described this in my book. My father's very generous. He's a very private person, but said, well, it's your story too, and has allowed me to kind of share this story. So he underwent prostate cancer surgery, and it was disastrous. So he became impotent and incontinent completely overnight, just in the cusp of his retirement years, just over in his mid-60s. And it was devastating for him, understandably. And so he had no history of mental illness. He was a career college professor of computer engineering, and I happened to be there at the time, so I witnessed a lot of this. And he was definitely struggling, with depression and this sort of anxiety, the cancer diagnosis itself, plus the repercussions of the surgery now. It was all very frightening. And he started to kind of speak in unusual ways and feeling suicidal feelings and whatnot. And at one point, my brother and mother felt anxious enough that they did what you're told to do, which is take him to a psychiatric hospital to get help. And it rapidly spun out of control, and they almost immediately incarcerated him against his will and proceeded to just throw drugs at him. And he got clearly dramatically worse, barely able to stand or function. It was just 5 different drugs at once. It was just shocking, really, for all of us. And then they proceeded to, well, that's not working. Let's try electroconvulsive shock therapy. And we were all kind of aghast. You still do that? Yes, it's a first line treatment for people with treatment resistant depression was kind of the story we got. And we're frantically doing research to sort all this out. And then what are my dad's rights, trying to understand the laws and all of this. And anyway, in and out of the hospital over a 9-month period, he got dramatically worse and suffered pretty severe memory loss. Now, he did get a lot of it back over the course of several years, but not all of it. So he suffered pretty important long-term permanent memory loss from the electroshock. And yeah, the drugs didn't help at all. He ultimately weaned himself off the last benzodiazepine that he was on. And yeah, so we had witnessed this, and that just made me say, wow, if this can happen to my father, literally almost overnight, go from the person he was to a certified mental patient being treated against his will. I wondered, who else is this happening to? And I just started looking around to try to find people. Those were the people I wanted to talk to. I didn't want to, I wasn't most interested in the psychiatrists or the professionals at that. I was most interested in what is this like to go through, to experience this? And do people get better? Do people ever get better? Are they all as traumatized as my dad obviously was from this experience? And so on. And that's when I began researching and writing about it.
So it's clear that there is a very dark side to involuntary commitment, because I feel like most people, when something's happening to a loved one or it's happening to themselves, they go, oh, I better go and talk to my doctor. That's what you ever hear. If you're having a hard time, talk to your doctor. And then the doctor will tell you, call, go to the emergency room, they'll be able to help you there, or they'll give you a number, call the suicide hotline if you're having problems. And people will do these things thinking, I'm going to go and find a sympathetic ear, someone who can hopefully counsel me and, point me in the right direction. But before you know it, they've said some keywords like, suicidal thoughts, and they're getting swept away to a locked unit. And, I guess as was the case with your dad, if you, I don't know, if you say the wrong things or you come in front of a psychiatrist that's very med heavy and you get put on a med and they make it worse, before you know, things have spiraled out of control and you're on cocktails of drugs. And it's like, how did this even happen?
Exactly. It's so shocking for people who've never experienced it before. It's still traumatizing even for people who have, because the brutalization just adds up if you're a person that is struggling a lot and ends up in that kind of circumstance. But as you're describing, for a lot of people, it's very shocking because they're expecting something like my father, something totally different, a sort of warm, caring, supportive environment. Instead, it was like this sterile ward. He was put in a room with some, young man, and just sort of like someone from a very different kind of background and experience. So it was very uncomfortable for my father as coming from his background, and then all the accoutrements of his life lost instantly, right? His sort of nice big home on a lake we're overlooking, and now he's just sort of locked up in this horrible little environment with a big bulky security guard kind of intimidating him. The very fact that the police showed up at one point to haul him away, handcuffed him, right? Like just all these things. He wasn't threatening anyone, right? Except in this very, obviously just expressing his emotion kind of way, where he might go, oh, I just want to, I feel like killing people or whatever. And I'd say, oh, Dad, you don't really. And you're right, son, I love you so much. If he literally changes that fast, he just needed to get some of these feelings out that he was experiencing. And that wasn't there at all, like for them. And I'll never forget the voice of a nurse who said to me at one point, I've never seen someone as ill as your father. And I was like, really? I've seen lots of people who go through this kind of a depression where they just don't want to get out of bed for a while. And that's basically what it was. And, being a bit stubborn in their wackiness, as he tended to be. But it was the fear and the judgment in her voice, like this was some horrible thing that a person could even go through this. And that kind of started to epitomize to me everything we've gotten wrong now in this kind of care environment, that it is far more like a policing environment than it is like a caring environment. And I think it's important that people know that before they run these kind of risks that you're talking about, where they are revealing.
It's a story about what happens on an inpatient psychiatric unit, because intuitively it's not what people expect. If you've never heard of it, you'd be like, wow, if you're having a psychiatric emergency, you'd probably go in there, you're probably talking to counselors every day, you're probably getting therapy, they'll probably bring your family in there, really wanting to understand what's going on with Dad. They're working with the family and important relationships, maybe social workers, to try and help get this person's life put back together. But it's not that at all, because psychiatric care in the United States has, it's all about efficiencies. And, to do all of these things requires, a doctor or a psychiatric nurse to sit with someone and kind of understand what's going on. And gosh, that takes a lot of time. But when you have medications, you can just use the medications. And it's, FDA approved, and it's a lot more efficient. It requires a lot less time. You don't have to kind of wade into someone else's sadness and kind of be like, oh, try and put their life back together. And so using the drugs is a lot easier. And really the experience of being in a psychiatric hospital for many people is you kind of mull around some shared common room, and then you get called in to see the doctor for 5 minutes in the morning. They'll, hold the dose, increase the dose, start a new med. That's essentially the extent of the conversation. Maybe you have one discussion with a social worker while you're there, and then you do arts and crafts in groups. And then they hold you there for, 5 to 7 days until your insurance runs out. And then they cut you loose and say, well, we've done everything we could here. Great job to us, pat on the back. They've essentially just processed you through a system, milking your insurance. And if there were legitimate things that were making you unhappy, they haven't addressed them. They've kind of masked them with drugs. And anyway, that's essentially what happens in a lot of inpatient psych experiences these days.
Yeah, exactly. It's rare that is not the case. And that's what I found through all my research and talking with professionals as well as patients. They'll often describe a similar kind of environment. The professionals may be protesting it in their way, like, hey, we don't have any rooms to do therapy at this hospital. Like, give us a break kind of thing. And yeah, but you're locking people up in this environment and you're promoting that as somehow a solution. And of course, the patients are protesting it. And it's brutal. And what I found through the course of the book is that this tool, strangely enough, socially has become much more broadly used than I think people realize. So it's not just used against sort of a really severely troubled person who's maybe already fully off the rails in their life, in the sense that they don't have any housing and any work or any friends. They've cut off all their bridges. People like that do exist, we know. And they need a lot of support to kind of come out of that, and I think deserve it. But they're not the only people that this is happening to by any stretch of the imagination. In fact, as we discussed earlier, it seems like in some sense, these are people that some hospitals are reluctant to even take because they know they can't really help. And so what I found through the course of the book is that all sorts of different environments are being, this tool is being used in those kinds of environments. So, for example, in nursing homes and long-term care facilities, so a lot of coercive medicating going on, using antipsychotic drugs, most typically to tranquilize people and try to make it a more controlling environment. And then children in schools, this is where the numbers are going up most dramatically. So it looks like a lot of teachers and administrators in the school system are seeing the opportunity to call 911 and get police to come and take children up to a psychiatric hospital as a better alternative than doing something else. And so it's become a disciplinary tool, it seems, in school environments.
It's so much harder to, if you have maybe a troubled foster kid or something in the home who's acting out and lashing out and having problems, to form a relationship with the person, to get them into therapy, to understand what's going on, to really invest in them. And it's a lot easier if they're having problems to say, oh, well, I'm just going to call 911 and let the professionals take care of it. And I mean, that's what a lot of inpatient psych is. It's a dumping ground for difficult people. So, I mean, if you're a family and you're struggling to care for a family member because they have behavioral problems or drug problems or they're becoming senile, and you're just like, I just can't deal with this anymore. They dump them in the hospital. They say they can't take them back, and then they get set up to go to like a home. Sometimes when they get put in the home is understaffed. And if the person requires if the person is irritable or unhappy or kind of, an irritable person, they go, I don't want to deal with this irritable person. Like just sit in your bed and shut up and, play the games and, watch TV. And if you're unhappy or something's going wrong, I don't want to hear about it. And if you make me hear about it, I'm just going to say, oh, we'll tell your doctor. And then the doctor says, go to the emergency room. And then they send you to inpatient psych. And then eventually they essentially drug you to the point where you're not going to be a difficult person anymore. And that's where this That's where this is all happening on inpatient psych units, until someone's so docile, they can fit the mold of what the nurses or the foster parent, the foster home wants them to be like.
You're describing what I think is one of the main reasons that the numbers of involuntary holds, these short-term holds, have gone up so dramatically. It seems to be that it's being commonly used by housing managers, group home managers. This is where a lot of people are today. We did close those large asylums. And so where have people who are struggling ended up? Well, often it's in these kind of smaller residential types of facilities, but they're still highly coercive environments. And the managers of the environment, the directors, are often utilizing the involuntary commitment laws as a form of punishment and management and control in these environments. And so what's happening is somebody does something wrong in the group home, gets someone else angry or upset. The manager says, okay, you're going up to the hospital. The hospital might hold them. The doctor up there may immediately know how you're not really meeting the criteria here for, maybe our beds are overloaded. How about, we'll just boost your medication dose a bit and send you back.
They lie sometimes, and doctors know this. They go, oh, this is really a social admit, but we need to get insurance billing. So this is schizoaffective disorder. This is bipolar disorder. Whereas if you just talk to them, it's like, oh, wow, this person is in a group home and they're unhappy because their parents aren't seeing them anymore. And there's someone else there who's like picking on them. So rather than it being like, oh, here's the context of what's happening to this unfortunate person and who's who's legitimately unhappy, bipolar disorder, relapse, schizoaffective, we're going to admit him in this way and then and essentially use drugs until the person's not unhappy anymore.
Yeah, and that's a powerful testimony you just gave, because essentially it's describing, really it's a form of fraud, right? I don't know what the right word is, but it's lying, it's deception, it's manipulation of the commitment laws and the criteria there, which are very broad, admittedly, and allow for that in a lot of ways, as the diagnoses themselves have a certain flexibility within them that can be applied in a lot of different circumstances, different ways. And so essentially, though, it does seem to be that in a lot of cases, doctors are just kind of making a decision like, do I want to lock this person up or not? Do I want to forcibly treat them or not? If so, then I'll make up the rationale. It's not the opposite, like, wow, okay, we never really want to get there, which is what it should be and what a lot of people think it is. It should be, no, we never want to go there, but okay, this. It seems like we have no choice in the matter here. We may need to detain this person against their will. We may need now to proceed towards forced drugging. It all seems to happen very quickly, and it's often just justified around just this initial impression somebody got, like, oh, this is a way of handling it. If we just drug them up, they'll be quieter, and oh, okay, that's an apparent solution.
Yeah, I mean, at the heart of what's going on is the fact that our mental health system is not set up or resourced in a way to actually help people without medications. Because when you dump someone in an emergency room who's having problems at the group home, what you want an emergency room physician to call the group home, figure out what's going on, negotiate with other group homes like in the community area and sort of make the case, hey, this is this patient, you should take them. And are they going to call the family member and say, we've got to, you maybe do a family session or something like that. No one wants to do that work. The system doesn't compensate for it. We don't have the staffing for it at all. And so it's just, ER doc's hands are tied because he has to, quote unquote, do something because you can't just send him back to the place. And so unless they want that person to just sit there like a rock in the emergency room, they have to, quote unquote, do something. We've now treated his schizoaffective disorder. We sent him to the hospital and now he's stable, even though nothing's changed. And these people, they usually just rotate in and out of psychiatric hospitals because they never really get better. And so many people that I used to work with would just go in and out every 2 to 3 weeks, and that was just what happened to them.
And we're actually creating a couple of generations now of people like that, of patients like that, by training children in this way. And it's one of the most shocking numbers that we see, as I mentioned earlier, is the rise of these detentions of children and youth. And why is that happening? Well, one of the reasons is because we're doing very, very aggressive education in school systems and to children and youth, this powerful outreach and media education that, if you're upset for more than 2 weeks and this, that, and the other, a few little coping strategies you tried hasn't ended your sadness or your anxiety, then you may have a biochemical imbalance. You may have a serious disorder. You need to see a professional. You should go to the emergency room. Like, we're actually training teachers and even fellow students to kind of tell each other, you should go to the emergency room. You should call 911. And so we're seeing these skyrocketing numbers of children and youth checking themselves into emergency rooms. It's one of the dominant things that's contributing to overloads in emergency rooms. So they're coming there. And I've even heard doctors, I don't know if you've heard this, but I've heard doctors that work with children and youth say, these youth will often come in and they've already self-diagnosed. Well, why are you here? And they won't even talk about their own distress. They'll say, because I have a biochemical imbalance and I need a drug to correct my brain. And the doctor, if they're at all progressive and critical, may need to kind of back up the children and the parents and say, well, let's explore everything that's going on here. That's a huge part of this problem right now.
Yeah. And, the sad thing is that they, and I felt this pressure as well when I used to work in emergency rooms. You can do that and say, let's pump the brakes and let's talk as a family. But then you've got all these other patients there, and it's easier to just say, well, I think inpatient psychiatry is the right call. The doctors over there will take care of it. And they don't.
Right. And on top of that, social workers tell me that they're now being told they have no choice. So social workers used to do some sorts of that kind of work, right, in the school system. And they would talk with parents. They would talk with children. They would explore the whole environment. But now they have a checklist. And if that child has expressed a suicidal feeling or something like that, boom, inpatient psychiatry is where they're not even allowed to actually participate, So in some way, we're undermining the very systems we put in place to actually help in this system. And we're putting all the pressure and all the expectation upon psychiatrists. And I feel like psychiatrists need to speak out in protest against this responsibility,
Well, there's that legal side of it, right? It's like, the patient came in suicidal and you didn't send them to inpatient psychiatry? Didn't they need a higher level of care? And so just on that side of things, if you want to sleep easy at night, knowing that, if something were to ever happen, you could point and just say, well, I sent him to a higher level of care. I sent him to inpatient psychiatry. There's also that pressure that just kind of feeds the beast. It keeps people churning through this system where the insurance companies just like milk the money out of patients. And the other thing I wanted to say is, you were talking about kids self-diagnosing themselves, and all of these maybe campaigns out there where teachers are educating kids on mental health problems and what to do. There's no problem with those campaigns and getting the word out there, like, hey, reach out for help if you're struggling. The issue is that it feeds you into a machine that doesn't really help you. It feeds you into a system that just kind of wants to sort of, quote unquote, process your case in as efficient a time as possible. And usually just means like giving you drugs and kind of working you through a system, which obviously makes you worse in the long run because it doesn't get to any of the underlying issues going on.
Yeah. And one of my biggest problems with these educational programs like youth mental health first aid is an example of a really common one. And there's a slew of them out there. You know, in all of the ones that I have read, I have never once seen any one of them at least just include a caring caution about, okay, if you do go to an emergency room, if you do see a mental health professional, you should be aware that you're now in an environment where your rights are at some risk, potentially, depending on, right? Children are never educated about this side of things, which can really happen. And so again, for these children, it can be enormously traumatizing. There was an excellent investigation of this by the representative for children and youth, a government appointed arm's length body in British Columbia that interviewed children about their experiences of this. And they'd just be aghast and they'd describe, I was restrained in this bed, some 12-year-old child who was just acting up in school and ended up with this diagnosis and then being restrained in a bed and forcibly drugged, and this going on for weeks off and on, and this child just completely, their lives devastated. And maybe they were already living in foster care, so they don't even feel a loving environment necessarily in their home life that they can fall back on. And so these people are just being absolutely traumatized and beaten in this kind of environment. And how does that, affect them through the course of the rest of their lives? And this is a phenomena that's just, it's not rare at all. It's really common.
But to warn people about it would be to acknowledge, like, yes, you should reach out and ask for help, but be careful of those psychiatrists because, before you know it, things can get out of control. And so if you were to warn people about it, it would be to openly acknowledge that the current system is totally wanting and, quite dangerous to people and quite cruel as well.
It would be radical. And but I think, at the same time, I don't think any independent observer really, if they think about this, would they advocate? No, we're going to mislead. We're going to lie. Like that's the intent. I mean, I know people do. That's why this exists, because I'll frequently bring this up to the writers of these kinds of educational programs and say, why wouldn't you at least mention this? Why is it not there at all? And so I know it is a deliberate attempt to hide and obscure that. But I think the broader public, I would hope, wouldn't have that same feeling. So I feel like, we need to make people aware that this is going on and hopefully say, we either need to radically change the system or at the very least educate people about these risks so that they can make an informed choice.
Gosh, yeah, that's crazy. What I do want to touch on, Rob, which I think is important to do, just to have a kind of a balanced conversation, would be to talk about when involuntary commitment works well and when, at least, I mean, we may have different opinions about this, but I'll at least share my own on it. When I think it actually works and it's a good thing to potentially take away someone's rights and haul them in for a hold. And probably the best use case scenarios of involuntary commitment is when someone is manic. So when someone either has a bipolar disorder and they're manic, or maybe they've had a reaction to some methamphetamine or cocaine, and they're behaving in a disinhibited and dangerous way. They're saying crazy things online. They're spending money. They're damaging their reputation. And these conditions usually burn out pretty quickly. If it's drug induced, once you stop the drugs, it goes away. If it's just a true manic episode, usually that's mostly burnt out within two, maybe 3 weeks. And the person would be very grateful for having been hospitalized because at least there was a container. So they didn't go and, blow all their money and ruin all their relationships and completely tarnish their reputation. That's a good time to use it. And there's also other situations where, maybe there is someone who has dementia and they're aggressive and they're in their nursing home. And, the reality is we don't have the resources to kind of plant a nurse next to every single person with dementia who can, who's able to sort of redirect them when they become confused. And the hard reality of the world is if you don't have a lot of resources for that, you do end up relying on drugs to kind of make some of these folks calmer because it's easier to care for them. And yes, so if someone is acting out, they can go to the hospital, and if you have a good psychiatrist there, they can make some tweaks to the medications and hopefully get that person in a more stable place. And making med changes is risky. You do want to do it in a place where maybe a doctor could see them every day. And so for me, there's this mixed bag. There's times when the care can be good, and then there's times where it can be completely abused, and it doesn't make sense. So maybe I want to get your thoughts on that, Rob. How do you see sort of, I guess, benefits of involuntary commitment on your side, if you do?
Yeah. Well, there's a few situations, a few ways I would comment. Like those are two very different examples you used, and I want to comment on both. But, there are a few things I found. So in some cases, people did say to me, yeah, I'm glad it happened. I'm glad that I was committed. And usually what I found out in talking with them is that they were treated really respectfully. It was collaborative. So yeah, it was kind of like, hey, look, the doctor might talk to them in this sort of way. Hey, this stuff's really going on for you. I can see we really feel badly about this, but feel like we need to keep you here. Have you ever tried a medication before? Would you like to try one? How about we look at that, see how you're feeling? We can lower the dose if you're having anxiety. Like it's a collaborative environment over the course of maybe a few days. It's a comfortable experience. There aren't people like maybe the whole hospital has this attitude. So it's not like this frightening, abusive environment where people are screaming in the other room right next to you as they're restrained. So there's just it's a nice environment. And I think it's important to highlight that those exist, and it doesn't take a lot to create them. That a really good attitude from all the practitioners involved can create a more caring space for people that can really make a difference. And then it's not so much about the force, it's about the collaboration in that environment. So I just want to speak to that a bit. And in fact, there are studies that show that too, that really the issue here is perceived coercion. If the patient starts to feel increasingly pressured or forced, then they're less likely to find any benefit from the situation. They're more likely to feel traumatized. But if they don't, even though they were involuntarily committed officially, if they don't feel that kind of pressure and coercion as much, they're more likely to have a positive experience. Now, in the other examples, I agree. I think one of the most important ways we could highlight what works and what doesn't is separating out detention from forced treatment. Because it's one thing, I think all of us can probably easily come up with a situation where we sort of imagine, gosh, like that's a situation where there needed to be some sort of physical intervention to stop something very dangerous from occurring. So that's a detention. That's holding somebody for a while to stop something from happening. And I think it's easier in my mind to see some situations where that can be more readily justified. Your example of somebody having a strong reaction. Maybe they haven't slept for like 5 days in a row while they've been taking meth or something, and they're hitting a really psychotic state, and they're running around and they're doing all sorts of dangerous things. And that just stopping this person, kind of putting them in a controlled environment for a while, they'll end up getting some sleep. You'll end up processing and getting through it. That I can see that kind of environment potentially working. And then the other, though, really much more problematic in my mind, because as you know, it's not actually, there's a black box warning against giving antipsychotic drugs, particularly to that group of people who have dementia in a nursing home. So we really need to look at how we're managing those nursing homes and I think recognize the risk to them, like that we're increasing death rates, I think almost by double within a matter of months when you give it an antipsychotic. And so what I like to highlight is just what's important is to broaden out our public discussion around this. I don't think you and I will necessarily settle, or even will mean that much, whether we settle today on every single situation and where you might stand and where I might stand. But I do think we can agree that there needs to be much more broader and robust public discussion about all of these kinds of situations and which ones might benefit from what kinds of interventions. And we may land on some where we go, this is the best actually just for police. The police should take that person and put them in jail. And I've had people say that to me. I understand why the police threw me in jail. That's fine. What I don't like is no, instead they diverted me at some point into a psychiatric hospital and they started mucking around with my brain. And all I had done was run up and down the hallways of my apartment creating a ruckus. And that's an offense of some kind that deserves a punishment perhaps. But why that? And what's the justification for that muddling with my brain? And so that's what I think we kind of want to flesh out the dialogue around. Who are we applying these to? What sorts of circumstances? And are we actually justifying a policing intervention of some kind and just asking psychiatrists to play like police officers? If so, let's make that clear, put that in the law, make it clear what it is. Let's not call it help. Let's call it a policing intervention, versus no, we really think this person would benefit from true help and care and support. And so what does that environment look like? And if that's what it is, let's make sure that the environment actually is created in the appropriate way.
Yeah, you bring up another interesting thing that I remember a lot from being in psychiatric hospitals was the amount of people who would get dropped off in the psychiatric hospital for things like trespassing or for being like a public nuisance or public nudity, these different kinds of things which are really legal offenses. The cops would just pick them up and they would take them to the psychiatric hospital because they don't have to process them. So there was less paperwork. They could just kind of send them to the ER. A lot of patients learnt this over time, that when they got in trouble with the police, they should say that they're suicidal, because then the cops are more likely to take them to the hospital because there's no psychiatrist at the small jail. So they would use it in that way. And again, it was one of these things where the cops were happy to because they didn't want the paperwork. They just wanted to hand them over, and the patient's happy because they don't go to jail.
Right. And that can be risky, of course. Yeah, it can be risky because, of course, we do have studies showing that if you kind of say, plead not guilty by reason of insanity, the equivalent of that for a serious criminal offense, you're more likely to end up locked up for much longer in a psychiatric context than you might have had you simply said, yeah, I committed the crime. So there's that to consider. But we have so many investigation studies showing that this is really common. And in fact, you understand it because police are being educated and told, as are judges, that, this is the right thing to do. We're going to help those people instead of putting them in jail. So they're actually being educated to take this approach, and it may not, in some circumstances, be of benefit at all for that particular person. And as you said, it could actually just be an administrative thing. It can, in some environments, it can be easier. I have to say, police have told me in certain jurisdictions, it's actually harder for them to bring someone up to the hospital. They have to stay around, until the person finally gets interviewed and admitted, and it could be hours, and they hate doing it because hey, that isn't what they were trained to do in the first place. So I kind of heard both of these messages from police working in the field. There's just no question though. What's happening is that involuntary commitment mental health law powers are being used more and more as a policing tool in these kinds of environments, one way or another, whether the person gets taken to jail or they get taken to a hospital emergency room. One way or another, it was a policing intervention. It was an owner of a business complaining about somebody, defecating in front of their store. And maybe they thought, this will be a nicer way. Rather than sending them to jail, I'll advise that they're acting crazy and get them taken to the hospital because I'll think I'm doing something nice for them and helpful for them. I think that's a message out there in the public too. Whether or not that's true in any individual case, or whether the person had a malicious intent, or whether they just called 911 and the police made the call. Either way, what we're seeing is a very, very robust using of involuntary commitment powers as policing tools in all sorts of environments, in the street for sure, in huge ways, in shelters, but also, as we talked about earlier, in schools, in other kinds of contexts, in workplaces even. There's all sorts of ways in which this is being used as a management tool or as a policing tool.
Yeah, as a way to get rid of difficult people and potentially have those people sort of drugged until they're more palatable to society.
Yeah, and feel like you're doing something good, while you're doing it, something compassionate, because that's what we're told. And so that's why I do think a main part of our task here is to educate the public that no, what you're doing is a potentially very brutal form of punishment, policing tool. So at least be aware of that. Maybe in some circumstances you believe that's justified. We can still debate that, but at least let's be clear about what the intent here is. Like, I don't think people have this illusion that when you send somebody to jail, that your intent is to help them. It may happen. Sometimes people do get positive things out of being jailed, but that's nobody's intent in a lot of cases. It's to protect the public, not protect you. But we have this sort of inverse story being told about psychiatric incarceration that is not true in a lot of cases. It can be a very brutal experience, frightening experience for people to go through, and often lifelong traumatization results from it.
So, Rob, I want to shift gears because we have touched on something a few times, and I don't think we've given it its sort of time in the sun yet, and that is involuntary treatment. Could you give a overview of what involuntary treatment is and what that looks like?
So essentially, the toolbox that is available to psychiatrists overall in society, which is mainly today the range of psychiatric medications from antidepressants to antipsychotic drugs. And these are, of course, as you well know, marketing names for these drugs. And often they interrupt or impair the function of neurotransmitters in the brain in some way, that they're designed to kind of numb feelings, or whether they're designed for that or not. That often one of the most common effects is that they'll numb or diminish sensation. It can actually diminish functional capacity in the case of antipsychotic drugs. And so these are the tools in the toolbox, as it were. And then electroconvulsive therapy is still not uncommon in use today. And those are the sort of main treatment tools that are used. And many people who've been through this, particularly when it's been forced on them, really hate the use of the term treatment at all, because they don't find it as treatment. It's sort of the difference between sex and sexual assault, right? There's a big difference between those two things. And the difference is consent. And that's what somebody says. Sure, you may, voluntarily try a psychiatric medication and find it helps you and continue to agree to take it. Well, that's fine. Like, I don't think there's a lot of people protesting that. If you're adequately informed about the possible risk and you're making that weighed decision. But this is an environment where people are being forced to take it against their will, often even when they've said, okay, I've tried it, I'm experiencing it now. Even now, I do not like it. Please take me off of this. And it continues on. And really what's happening is, because there's no evidence that this is really helping people. We don't have any kind of studies that indicate that over the long term, these are actually producing benefits on any scale, whether it's for public safety or for the person's own well-being and quality of life. As a result of that, a lot of people do end up going off of these drugs, sometimes too quickly, suffering severe withdrawal impacts and so on. And that can be really destabilizing to their lives. So this off and on thing has created a political movement to extend and heighten the capacity to treat people long term against their will. And so we're seeing a rise in assisted outpatient treatment, it's called in most places in the US, which is the ability to continue.
Just to talk about this assisted outpatient treatment, what it looks like is a team of people, like a doctor and a social worker and some burly guys, turning up to your home, knocking on the door and giving you a 1 month long-acting antipsychotic injectable against your will. That's what community assisted treatment is.
That's what it typically is. You're supposed to, typically get more other range of practical supports in your daily life and counseling, and that rarely comes in actual fact in these circumstances. It usually is just that. They visit your home wherever you are, or you're required to go in somewhere to get your injection. If you don't show up, they immediately contact police and haul you back in. And so, yeah, it's a very invasive kind of experience for people. They often can't go play. Their travel is restricted. They have to be home. They might be visited multiple times per week, but have meds witnessed. So whether they might not be getting only the antipsychotic injection, they might be taking other oral meds as well. And so somebody will show up, or they have to go to a pharmacy or somewhere and actually have somebody witness them swallowing the medications. It's very, very intimidating and uncomfortable, invasive, humiliating for people to go through this. And yes, so that's on the rise across our culture. And also a kind of, that's a very formalized form of it. There's an actual court order, but also there's an environment of something called assertive community treatment, which is essentially the same thing. It's just not court ordered now. You're supposed to be getting all sorts of voluntary supports with this, but often what it becomes is just somebody checking in on you quite regularly. And if you're doing anything that they consider a little untoward, or they're concerned about your well-being in some way, or they're just punishing you for some reason, they'll start exerting coercion. Look, if you don't take these drugs, we're going to haul you up to the hospital. We're going to contact police. And so a lot of people are living in that environment as well in our society. So this is what long-term coercive treatment is looking like. And yeah, as I said, it's kind of on the rise, I think, largely because people are seeing that short-term doesn't work because it does not convert people. People don't take antipsychotics and then miraculously go, oh my God, I've never seen, my life like this before. It's so wonderful and terrific. I'm going to stay on them forever. They occasionally do that, or usually not so robustly. Usually just like, okay, this is better than the hell I was in, and it's still hell, but it's, that's more often what you'll hear from voluntary patients. But it's very common that people hate the side effects. They hate the adverse effects. And more than that, they're doing real damage, and they can start to feel it and experience it. It can be detected. And so they're resistant to these drugs.
Yeah, it's a terrible thing because, if you're on long-acting antipsychotics, you can develop tardive dyskinesia, which is, it's brain damage, essentially, that is potentially irreversible. If you get ECT, if that's forced upon you, you can also develop severe cognitive impairment that can be permanent for some people as well. And so, these are not benign things to force upon someone. They can really damage a person's brain.
And I want to ask you there, why isn't that talked about more? Again, I just feel transparency would benefit public discussion so much if psychiatrists would routinely be telling legislators this and the news media this, and people that they talked with, like, hey, you need to know how potentially damaging some of these drugs are that we're forcing on people. So why you say it so frankly and straightforwardly? Why is that not the dominant message out there, do you think?
I think in a way it's because it makes their job harder. So if you're a psychiatrist and you have a set of tools in your toolbox and it's like ECT, antipsychotics, like I was saying earlier on in the interview, these aren't professionals who are kind of that interested in helping people, in non-drug ways. One, that might just not be what they're interested in. Two, they simply don't have the time to do that with patients. And so I think that they actually downplay the risks of the medications because it's easier for people to take them, and it's easier to convince people to take them. And so it's just simpler to say, well, this thing is kind of overblown. It's not that much of a big deal. Trust me, this is really the way to go. And when you talk up the medications in that way, you can handle people really quickly. You can have a visit that's 15 minutes long where you say, oh, we're just going to bump the dose or drop the dose a little bit. You don't have to sort of wade into the complexity of like, hey, there's actually a lot of risk here. And if you don't want to do this, man, we've got our work cut out for us because we're going to have to come up with some other plans to try and help you. I don't think they're interested in getting involved in discussions like that.
Yeah, and you're reminding me and continuing the discussion of what does involuntary treatment look like. That's it, is that if you trigger resistance in a patient, or if you inspire resistance, or for whatever reason a patient is coming with this kind of knowledge, they're already armed from their own research with this knowledge in a hospital environment, for example, well, involuntary treatment in that context looks very brutal, right? That then restraints are used. Security guards overpower people. They can be forcibly stripped. Sometimes clothing can get cut off by scissors. All sorts of very aggressive tactics can be used in that environment. So I'm guessing that's another reason that in that context, doctors don't really want to be really forthright about what they're prescribing.
Yeah. It's a terrible thing, what's happening, because essentially what you have is, I think in many ways, it's one, the doctors putting their own interests above the patients. But then maybe you would expect like the psychiatric leadership to say, hey, we really need to be more honest about these things. But, leaders of the APA and the big medical institutions, they're also about protecting their reputation and their image, and they have more to gain by just saying, nothing to see here. These drugs are safe and effective. Like anytime RFK or anyone else like brings up a problem with these things, you got to just ignore them. They're spreading misinformation. Just trust the science. Their approach is just like bury their head in the sand, despite there being hundreds of thousands of people online talking about, severe permanent brain damage from these drugs. They don't want to hear it. And so you have the professional institution and you have the doctors all sort of putting their own interests and just keeping the status quo because it's just easier. And the patient suffers. I mean, it's an absolute betrayal of what the mission of medicine is. And I don't know how we've allowed it to get this bad, but that's just where we are at the moment.
What you're describing there, the sort of institutionalization of these attitudes it's hugely impactful in this environment. And I agree with you. I think that's a big part of why this is playing out. We have these very, very profitable industries that exist on the basis of misleading the public about these medications, for example, and then the embeddedness of some of the mental health professional organizations with the pharmaceutical industry. And I think also part of that, there is an industry that finds benefit in having these kinds of involuntary commitment powers available to them at any time throughout society. There's various industries, and they're not necessarily the same. Like, I don't know that a pharmaceutical industry executive is sitting around saying, yeah, we want to boost involuntary commitment. I don't know if they're making that much money directly off of that and only that it's an issue on their radar. But they're quite aware that the overall movement of society in that direction is something that they support, and they openly, clearly support organizations that are pro-forced treatment. And so we really are up against I don't know what that industry is ultimately worth. In my book, I kind of play around with some numbers, but it's hundreds of billions of dollars going into mental health each year in the United States overall. And within that, involuntary commitment alone seems to be at least a $20 billion a year industry. So, yeah.
And the mental health of Americans is not getting any better. It would be worth it if people were, having the best mental health they'd ever have. But every single statistic I've ever seen is that mental health is getting worse and worse, and more people are on drugs. And so you're not even really getting anything out of it apart from, I don't know, padding the profits of the drug companies or the hospital chains that are owned by private equity who stand to make a lot of money, but churning people through this. One last point I was going to say is that the drug companies may be one of the reasons why so many doctors are afraid to speak out, because any time that people have ever criticized these medications, the drug companies have said, you're stigmatizing mental illness, you're trying to scare people away from the drugs. They launch ad hominem attacks at you to sort of shit talk your character and say you're out there for some, that somehow spreading information about the risks of these medications is a societal negative, where most people would just want to be informed of the risks. And so there's also these covert threats that drug companies lob at people who say, oh, you're causing suicides because you're scaring people away from taking the drugs.
Yeah. And I do examine some cases of that in the book, going back decades, of prominence, medical doctors or psychiatrists speaking out and getting hit with a basically character assassination, an attempt at career assassination, perpetrated against them by organized forces. And it's not only the pharmaceutical companies that participate that. As we know, there are certain organizations like Treatment Advocacy Center and the National Alliance on Mental Illness that tend to be very pro-forced treatment. And so they will attack those kind of people. And as you say, even just the people who simply raise questions about the medications, even if they're still supporting forced treatment, that piece of it alone is enough that will bring out those sort of wolves of attack. And I see it. I know what you mean. And I think that is actually a major factor. And that's what I do think we need to understand that we're up against this massive industry and institutionalization of attitudes in criticizing and raising questions about this. And honestly, one of the most shocking things to me is my own book and how, even though involuntary commitment is in the news, and even though my book is really the only book in the last couple of decades, or one of two books, I'd say, in the last couple of decades that really directly addressed involuntary commitment. And it's really the only one that looked at it in a very broad-based journalistic way, all the different ways it's being implemented across society. So even though my book's the only one that really is out there that exists, it's been largely just ignored by all these same news media outlets that are covering involuntary commitment almost on a daily basis these days. And I think there's something there. It's not like that I have been assassinated. I haven't been. Nobody's really come out after me in that particular way. But the just ignoring it, is powerful enough that most people don't know that these kind of critiques even exist.
Yeah, I mean, I think, and I know there's been instances where, journalists and news organizations have had to pull pieces that were critical of medications because they have sponsorship from pharmaceutical industry, and they don't want to lose their advertising that they're getting from. So I think, Rob, in the same way, people would look at what you're saying and just be like, that's not the kind of thing that we really promote over here. We're not going to touch that one with a 10-foot pole, because it's, you're getting at something that's near and dear to very powerful institutions, and they're just not going to want to make their lives difficult. Yeah,
I did have a very specific example of that recently with a very, very prominent, nationally prominent news media outlet that had invited me to submit an op-ed about the data issue. So we have very poor data about involuntary commitment across the nation. Mm-hmm. And so I highlight that because it's like, how can we be promoting something that we aren't even really tracking very well, how often it happens, to whom it's happening, and what the consequences are. Are people getting better or worse? What do we have to show for this rising rates of involuntary commitment that seem to be there, even though, we're just patching data together. So just making a case for that, like, hey, we shouldn't be promoting this as a method until we get our data in order. And so even that, like the response I got ultimately from the outlet was, this is terrific, very important, really needs to be published. Good luck. There was no, hey, we need it a little shorter. Could you tweak this or that? Okay, we got a problem with the tone. Could we change it? No, it was just like, we're not putting out this message, period. But we recognize that it's important, Yeah. Well, Rob, what else haven't we covered which you think is important for the audience to know? Well, I'll just mention that I am sort of trying to more regularly cover these issues in a new column on Substack called Psych Force Report. So if people do want to kind of stay up to date on that, and if you subscribe at a certain level, you get a free copy of my book with it. So there's that as well. Yeah. But I mean, there's so many. That's all I could say is just people have no idea. I was surprised. I've been researching this issue for 25 years, and even I was aghast as I worked on the book at the extent to which involuntary commitment powers are being used across society against whistleblowers, against protesters, against complainers to the IRS, but just all these different environments where these tools are used. And I think people would find that very interesting.
Mm-hmm. Well, Rob, it's been a pleasure having you on. Thanks so much for taking time out of your day to talk about involuntary commitment with our audience.
Okay, and thanks a lot for having me. Great to talk with you, Joseph.
If you want to learn how to avoid getting locked up by a psychiatrist, you're not going to want to miss this video right over here.